My name's Laura Miner. I am the Western Regional Representative for AEM, the incoming vice chair. And so students, hopefully the chat's working. I put another link to our benefits, so I always give a spiel to become a member, and I'll continue doing that. So become a member if you're not already one. There's tons of ways to get involved. And from there, Dr. Frederick, I'll let you present. If y'all would like to say your name and your role with the program, that would be a great way to start off. And then once you finish with the presentation, we'll open it up for Q&A. And from there, it's just answering questions. Thank you for joining us tonight.
Andy, do you want to introduce yourself first?
Sure. My name is Andy, and I'm the med student clerkship director. I'm also a graduate of this program, so I feel like I have a lot of opinions and enthusiasm. I'm also between nights, and I might be slightly disinhibited. So right now, maybe is a good time to ask me questions about the program.
Disregard anything Dr. Berglund says in that case. Not true.
It's usually a pretty good rule of thumb. It's true.
I am Matt Frederick. I'm the program director. And I guess I have a brief presentation that I'll go through. And then I think Andy and I are more than happy to take questions. You know what? Before I get started, I'm going to put my contact info with my phone number in the chat real quick.
Make sure you click to everyone instead of host and panelists.
Thank you.
And then students, if you're on and you're able to respond and let me know if the chat is working, that would be great. We changed the settings, so I'm hoping people can see this. Oh, yay. Great. Thank you, Adriana.
All right. Am I sharing?
Yes, you're good.
Awesome. Okay. Great. So this is hopefully just a nice little overview of our program. Definitely Andy and I are happy to answer questions at the end or any other time. Feel free to reach out by email or text or whatever is totally fine. All right. So quick facts about me, and this also somewhat applies to Andy. We're both West Coast Seattle folks who have relocated to the desert, and I think we're still working on drying out maybe after being rained on continuously for 12 years. I did a simulation fellowship and an education fellowship, and I became PD about 8 months ago. So our class, we have 12 residents per class. Caveat being, of course, that 4 years is potentially on the horizon. So who knows what that'll look like, but we're still a 3-year program currently. We usually have 10 to 12 fellows in our contingent at any one time. So like we have EMS, we have pediatric emergency medicine, we have wilderness medicine, we have education fellowship, critical care fellows that are in and out of the department, and sports medicine. I think I hit them all. So they are still a part of the residency program, even though they're fellows, and you will be taught by them and also be supervised by them on shift often. Wednesdays, we do our conferences, and then every third Wednesday is a day devoted to simulation conference. One thing that I think stands out and defines our program in a very acute way is our mission orientation. So if you're unfamiliar with New Mexico, it is a medically impoverished state. There is not a lot of there's no tertiary care centers essentially outside of Albuquerque. There's no trauma centers outside of us. And there really is no neurosurgical emergency center, ECPR center, neurointervention. Any of those things are pretty much all University of New Mexico. So we take care of a incredibly large catchment area, including sometimes from sometimes from Oklahoma, sometimes from Arizona. We occasionally take some people from Colorado and occasionally some people from Texas. So we do get a really broad range of pathology. I think that is a huge bonus for our program. And by virtue of that, we really try to focus on making our care and our understanding of medicine focused on the broad population understanding. So we are funded by the state of New Mexico to take care of people in New Mexico and to train physicians for the state of New Mexico. And we take that very seriously. And I think we do a really good job at it, but it defines all of our thinking and all of our program directions. Our department is a high acuity high volume center. We see about 85 to 90,000 a year. And of that, probably about 15 to 20% is what would be thought of usually as like critical care. We have within the emergency department a resuscitation unit that is currently 7, expanded occasionally to 12, 13 beds. And we'll have a few more beds and a new critical care tower, which will be opening in October. We do also see a very high volume of trauma, as already alluded to. Like, we get transfers, any trauma basically occurring in the state of New Mexico ends up in this resuscitation unit. In addition to Albuquerque does generate a fair amount of penetrating trauma. And so we see a lot of that as well. We do 8-hour shifts, generally speaking. There are 19, usually residents work 19 shifts per block. Our PEDS experience is longitudinal with the exception of a rotation in the intern year. And then SRMC is our community hospital experience. And that is also longitudinal, where second and third year you get shifts sprinkled in. We have scribes in a couple of the areas of our emergency department as well. Intern year, we start the year off actually with a full month of orientation, which I think is pretty cool. It's a great time for bonding with your classmates, getting your feet wet in the hospital. We don't really believe in just throwing anybody in. You only work a couple orientation shifts during that month. So it's a pretty nice July, I think. And then in addition, intern year, you're going to do 6 ED blocks. You're going to do 2 ICU blocks. We do an anesthesia, a peds anesthesia, and then a split tox ultrasound, an OB, and an EMS month. Second year, you're going to do 8 ED blocks. And the graduated responsibility there is you become the senior resident for the emergency department resuscitation unit, which is a somewhat daunting experience, I think, at the beginning of second year, but ends up being really, I think, one of the crown jewels of our program is like this little 200 square foot area where we intubate people and do CPR and put in lines and like literally save multiple lives on an everyday basis. And it's a privilege to get a chance to work in there. And second years is when you start getting in that area. We do 3 ICU blocks. In the second year, you do an ultrasound block and then a dedicated orthopedics block. The orthopedics block is all emergency department based. So you're not like rounding on patients in the hospital and writing notes and that kind of stuff. You're not going to the OR. The goal of that month is basically to just do emergency department reductions and splinting. So I think it's high yield. And generally speaking, it's not super taxing. It's usually about 6 hours in the evening when our trauma is the highest. Third year, you're going to do 8 more ED blocks. You're going to do a full month out at our community hospital, 2 ICU blocks, and then you have a couple electives. The graduated responsibility for third year is you become the trauma team leader. So when we have like our level 1 traumas, our trauma team comes down and we have a multidisciplinary team because of that. And we have a resident that runs the whole trauma. So the attending kind of stands back. The resident's the captain of the entire resuscitation. And the third year ED resident's the one that takes that role on level 1s. We have a couple tracks. These are malleable, I would say. So I won't belabor all the details of them, but just know that if you have interest in these areas, we have resources to help guide you into experiences that will be formative and help head you in that direction for your career. The things that I think stand out about our program are critical care. Aside from the really high level resuscitation we do in the EDRU, we also have, I believe we're at 11 current EM critical care faculty. So people that have done emergency medicine residency and then critical care fellowship. And they are dual boarded and work in both departments, which is an awesome strength. Like when you're in the emergency department, getting some like critical care type teaching on resuscitation. And then conversely, when you're in the ICU, having one of your ER attendings being your attending in the ICU and being able to cater some of the teaching and experiences more along the lines of like resuscitation versus like rounding type critical care. we have a really unique and awesome experience with EMS. Andy actually did an EMS fellowship and can probably answer more questions about that. But we have the opportunity for residents to become a part of our flight team and actually serve as the flight physician and get moonlighting pay for that. And it's pretty cool. New Mexico with all these like remote critical access hospitals, like you get called out, you're going to fly in a helicopter out to one of these remote locations. You may have a scene call, or it may be an inter-hospital transfer where you're showing up and putting in a line and putting in an art line and starting a person on pressors and getting them packaged for the flight back to Albuquerque. We have some awesome wilderness medicine experiences, the opportunity to earn a diploma in mountain medicine while you're a resident that is covered, the cost is covered by the program. Then we do have quite a bit of social emergency medicine type work that we do. We don't have a formal fellowship in street medicine. I would love to see that started someday, but nevertheless, like we do have a very active cadre of people that are working on both substance abuse issues as well as like just street medicine. If you've never been to Albuquerque, I would say that it's a unique place. It's super laid back. The culture is very much like still a mix of like Spanish culture, Mexican culture, Anglo culture, all like interacting and interweaving with each other, but still having some of that still like very much standing up on its own. And the native culture and our native patients are a huge part of what we do. The Navajo Nation counts on us to be their backstop for most of their tertiary care. And so because of that, like we have a really unique relationship with that patient demographic. And then I guess lastly, I'll just say a little bit about the city. If you've never been to New Mexico or Albuquerque, it's a pretty under the radar place, but it's really cool. I live on like the east side of the city, which is basically all there's just a big mountain range right behind my house. And yet I live like 12 minutes from UNM. And then there's also like Nob Hill, which is like a little bit of a cooler area that you've got some restaurants and stuff. But the outdoor recreation here and the beauty of the sunsets is, I think, probably unparalleled in a lot of ways. And it's not super crowded. A lot of people haven't discovered it yet.
All right. I'm gonna monitor the Q&A in the chat, but as we wait for stuff to come in, I would like to just hear more about what brought both of you to New Mexico and just your path into the admin for New Mexico. Or not admin, but your role as program director and then in working with the residency program.
Yeah. I think both of us were a little bit non-traditional academic paths. Andy, you want to go first?
Sure. This is one of my favorite topics is just talking about myself. So I appreciate that opportunity, Dr. Fredericks. But in all seriousness, what brought me here to UNM was the EMS component and then the critical care component. Previous to medical school, I was a paramedic. So the whole EMS thing was really important to me. And one of the things that I thought was really great about the program was that they were very flexible. And Matt highlighted like there are, I think when you're looking at a program, you should imagine what opportunities can they offer you and like where do you see your future? And is there someone at this place that is doing the thing you want to do? And so for me professionally, my interest in EMS, like there were definitely a lot of faculty here that were doing research in different populations, whether it's the rural and austere medicine or tactical medicine, which is one of my interests. There were a lot of people just doing the things that I wanted to do in the future. And so being able to come here and get that kind of mentorship was really great. And then I think without, we have, we run the risk of emphasizing outdoor stuff a little too much sometimes, but I think it's important to be able to be somewhere that allows you to have a chance to step away from work and recharge and refill your cup. And that could be different for, obviously it's different for all of us, whether it's like living in Manhattan or being on the beach or whatever. But I do think that it is important to be in a place that allows you to find a way to recharge yourself. And as Matt highlighted, like Albuquerque has so much cool outdoor stuff to do that it's just really easy to access. And yeah, I lived in near the foothills like that Matt describes. near the university, so relatively close to the campus, but I was also 30 minutes away from my favorite skin track in the Sandias or like great mountain biking. That's pretty nice. I am obviously no longer a resident here, but I feel as time has passed, we still really allow residents to have an opportunity to build their own path, as like Matt highlighted with the tracks. And I think that is so cool. It gave me a chance to, if I can talk about my CV a little bit, but like when I came in, there was no flight program for residents. And so I asked some of my faculty mentors who are also in charge of the lifeguard program. I'm like, hey man, can we get residents to fly? And they were like, sure. We just need someone to like lead that project. And so they let me like create a whole pathway to allow residents who have never done anything to fly, and not need like a background in paramedics or nurses or whatever. And I think that was a really cool opportunity to like get some growth and some leadership and then develop something cool for other people to do. And yeah, like finding a place that lets you explore those sorts of things is so rewarding, and can't emphasize that enough. And it doesn't have to be here. Like it could be anywhere. Like one of the things you guys are going to be doing is being consumers of residency programs. And you should think about, what is this place going to offer me besides good residency training, which is implicit in all programs, but what is the extra stuff that they can get you?
Yeah, that's great, Andy. A lot of that resonates with me. I came here initially mostly probably due to my wife's path. So she is a PhD student at University of New Mexico in Chicano studies. And I basically told her, like, I'll go wherever you want as long as they have a teaching hospital and mountains or an ocean. So that's how I ended up here. I've stayed and took on the position of program director primarily because of the people. Like the residents and the faculty care so deeply for the people we take care of. And the residents are just like, they're some of the best people I've ever met. And I think Andy's experience with lifeguard echoes what a lot of people would say with different projects, right? If you're interested in something, I think the institution and the department is super supportive of seeing that come to fruition. And that's the kind of place that I want it to be. And those dual missions of educating, seeing people grow, and also taking care of a population that like legitimately needs you. Like when you go to work, you feel like you're doing something that's worth something. And I know that probably to a lot of med students seems strange to think that like you would lose that feeling. But honestly, like I did for a little while when I was practicing in Seattle. Like when you're in a very over-resourced place, you get the sense that anybody would be doing your job, versus I think there's a real sense of fulfilling a need in New Mexico that is, I think, really in line with why all of us went into medicine. All of us want to feel like we're doing something worthwhile. And I think at UNM, we have that feeling.
Those are both great answers. We have one question in the chat. Are there any changes on the horizon for the program, or what is an area that you all are trying to improve?
Lord have mercy. There are some big changes on the horizon. Yeah. So aside from like globally, what's going to come down the pike with emergency medicine, we're moving to a new tower in October, which is going to be a pretty remarkable improvement in our physical space, but it has completely upended like everything with our schedule and all that sort of stuff. So I would say that's a big change we're all working on right now. In terms of something that, I'd like to hear Andy's answer about something that he'd like to improve as well. But for me, I think I'm very passionate about us giving good feedback and giving feedback that helps to guide our residents into flourishing in their career. And that's an area that universally programs struggle with for a lot of reasons, but it's one that we're like actively working on. And at least we may never get to the point that we'd like to be, but at least trying to be a leader in that realm.
Wow. As Matt knows that I have many opinions, especially since, again, I feel very possessive about this program because I trained here and it's my place. But yeah, like we definitely have some opportunities when we're moving to our new physical space, which will be great. As Matt alluded to, like post pandemic and everything, like New Mexico has really suffered in terms of having enough just staff to like literally staff places. I worked in the community for a while before coming back. And the other, actually, Presbyterian is actually, I think, a larger system than us in terms of just overall like employees. They're a private system here in the state. And they also opened a new tower, and they like entire wings of the tower are still unutilized because there's no staffing. So that is definitely going to continues to be like a hurdle that I don't really have a good solution to, but we try to like make do with that. But yeah, I look forward to finding new ways to optimize our throughput through the ED. And like Matt had alluded to vertical care, which is like a slightly different way to do the job of working in emergency rooms. So it'll be interesting to see that in practice in the new tower. I don't know if anyone's familiar with it, but basically like instead of an emergency department where there's all these rooms and then you like walk around to individual rooms to see patients, the vertical care is a model that basically you stay in one physical space with a couple beds in front of you, and then you see those patients, and then they get sent to other places, either the lobby or to like ancillary testing. And then that space just gets filled with new people. And so that really does improve the efficiency, but it also can be a little bit challenging, especially for brand new interns. And so that's a fun way to expand our volume and allow us to see more people. But it is a little weird that people have to get used to.
Yeah, it might be worth like one or two additional comments on that vertical care model. So yeah, I think if we're honest about where emergency medicine is heading, it's that waiting rooms are acceptable to administration locally, and also like from a nationwide perspective, like it's just become the norm to board patients and have patients in the waiting room. And I think there's a couple different ways to go about handling that challenge. One is to practice like waiting room medicine, which we certainly do some of where we see patients in the waiting room. Another is to ignore those patients until they find a room, which I think is, I don't know, morally reprehensible in some ways. There's another option of continuing to fight against it and saying we're not going to accept this, which I think is a losing battle in the like funding structure of emergency medicine. And then the last one is finding ways to give patients emergency department care without an emergency department room. And so the new tower, I think, is embracing what is the new paradigm in emergency medicine, which is it appears most places will have more patients than rooms, but still giving patients the opportunity to be seen in a room and giving the residents a place to do a real exam and everything. We're already employing that model in an ad hoc way in our current environment, but the new tower is basically revolving around that concept. And I think it certainly got some downsides. Like I think the ideal model is patients get rooms and you see them in their rooms and they stay there. But that not being an option, I think this is a really inventive way to make sure that residents get the chance to see volume. The other upside is that ideally these patients that go to these vertical care spaces where residents are working don't go through an MSE process. So like the provider in triage that orders everything and then they go back to the waiting room. The residents ideally are doing all that work of seeing the patient de novo, entering the orders, getting the history and physical, and owning that patient for their stay, which I think is much, much better for education rather than seeing patients that have already been evaluated by a PA or a nurse or whatever, already had orders put in. And basically like at that point, you're just analyzing data and making a decision.
Okay.
Yeah, I would like to make it clear in case it wasn't like I'm a huge fan of vertical care in the community. We implemented it like 3 years ago and I have loved it. I loathe waiting room medicine. I think that, again, I have pretty strong feelings about what administration is asking of both patients and physicians in terms of what do they tolerate. by making them do waiting room medicine. Critical care though is phenomenal. I really think that I totally agree that it's like how the next model of caring for patients. And at UNM, we have a shortcoming. It's that we are so busy and medically complicated that it's hard for us to get good volumes for residents. And this was true for my class eons ago and for all of my classmates. Like we all had trouble, not with critically ill patients, but with just seeing a bunch of like low acuity patients. Like we just weren't used to it. And so this is a great way to see a bunch of low acuity patients while still maintaining high acuity because we still see those people. We just move through them more quickly. But yeah, it's really great. Someone had asked just in the chat about board exams, and we basically, you need to pass level 1 or step 1, depending on your training institution to be considered for an interview. But then in order for everyone to have parity, and this is what Matt and I were both DOs, we also did this. We took step 2 in addition to level 2, and we want everyone to have step 2 so that everyone can be compared like apples to apples for ranking. Did I get that right, Matt?
Yep.
Okay.
What would you say are the biggest needs for the patient population in your area, and go into like how exactly you give care to those reservation areas?
Yeah, man, where do we start? The needs are abundant. I think there's probably a really good public health answer to this that I don't have, but just in terms of our everyday practice and what we see, the biggest needs are timely outpatient care. People have an incredibly difficult time. I'm talking like a year plus wait for primary care currently in New Mexico. So because of that, we're definitely primary care for a lot of people, and we're really bad at primary care.
Yeah. Yeah, that is definitely true. However, UNM has, excuse me, UNM has, and this is to the credit of one of our, again, non-traditional EM faculty who is both EM and IM boarded. They're helped develop a post-acute discharge clinic. And so they're able to become primary care for our patients. And right now, maybe we just aren't referring enough people to them or something, but there's still like capacity to get good follow-up in a week, and then they will help establish primary care for this patient in either the UNM system or like a partner system as well. And so that is actually like pretty amazing. And that did not exist when I was a resident a decade ago. I think so our patients, especially our indigenous population, like they oftentimes, first of all, like they're like physically from us, hours away from Albuquerque. And then like oftentimes those pueblos do have a clinic there, but they're also pretty resource limited and then available only Monday through Friday. And so all of the basic stuff is like getting to appointments, getting to good follow-up, having, honestly, I know this is crazy, but like having electricity and like phones and stuff to be able to arrange all of that stuff is oftentimes a problem, especially for our native populations. But because so many of our patients also live below the poverty line or are experiencing housing instability of one kind or another, it's even for people who, quote, live in Albuquerque, as it were, they don't have a phone or they don't have access to getting a ride to the hospital. And that just makes everything challenging. Even if we had great primary care, if you've seen in your communities, like they'll have like various like Medicare related medical transport, like non-emergency transport in your town. And people who have Medicare or Medicaid, like they can get a ride to the clinic using a service like that. But unlike Uber, they're not reliable. So even just getting to an appointment, even if you have insurance, but just don't have a car or just unwell and can't drive a car, just getting to places is challenging. And it's just magnified by the lack of resources we have in the States. Yeah. As Matt highlighted, like sometimes we have to do a lot of extra stuff in the department for these patients, which then also has other knock-on effects for everybody else in the department.
Okay.
But I think one of the things I like that to some extent, not the patient suffering, but I like that it gives us a chance as emergency physicians to be those problem solvers. And I'll acknowledge that I didn't really get in this job to help arrange for home health care or solve someone's need to get a hospital bed in their room. But at the same time, like being able to do that for somebody, because if that's what they need, like that is actually really rewarding. And having complicated resuscitations and challenging trauma patients is cool, but it's also very rewarding to just meet people's needs in some really fundamental ways. And I love that about emergency medicine, both here and this is true everywhere across the country. I really think that's one of the things that we offer our community is that problem solving skill.
That kinda actually answers the next question I had, which was gonna be, like, since you guys are that primary facility that has everything that the patients would need for your state, it sounds like the residents get great exposure to all kinds of different things because everybody's headed to Albuquerque to get their care. But can you explain the partnership with the other residents for other specialties and how that works in your department, like with consultants or maybe how you guys run trauma with other residents, just what that looks like since it seems like you guys are all providing care for the whole state?
Yeah, I think at least from my experience, like this is my third academic shop that I've worked in, and it has the best relationships with our consultants that I've been exposed to. I will say that our the relationship with medicine, internal medicine, is actually like pretty much limited to off service rotations. So the way it works, generally speaking, is that our residents put in the consult to the attending internal medicine doc, and they're the one that sort of get up to the residents, which actually works fantastic. There is much, much less pushback than any place I've ever worked. And most of the pushback comes to the attending. And so it becomes an attending to attending conversation. So I think that's a really good system. And then the other team that we interact with the most would probably be trauma and orthopedics. Trauma surgery, I think we have a really good working relationship with. It's not without its speed bumps occasionally, but we have a pretty well delineated guideline about who's in charge of what. So we're always in charge of the airway. And then when there's a senior resident in the resuscitation unit, they're in charge of being the team leader. When it is a second year resident, then they're in charge of what we call doc left, which is basically like the procedure doc. And so those rules are pretty tightly regulated. And so we don't have fighting over domain. We occasionally have respectful conversations around management, say. But I think that's really educational. If you don't ever have those conversations, you're probably missing out on something. And then lastly, ortho, which is the other team that I think we interact with a ton. We actually rotate with them. I think our residents know most of them by first name and have rotated with them. And that is incredibly collegial. We do, because we're such a busy trauma center, we're doing some really high level reductions that frankly, like most community shops, would just go straight to the OR. And so they're relying on us to provide a lot of procedural sedation for them. So we have a pretty tight relationship with them as far as we're a team. Like we take care of the analgesia, they take care of the procedure. We can help with the procedure. We can do the procedure if we want. But I think our relationships are really good. We're always working at them, but I think they're solid.
Yeah, I totally agree. When back in my day, actually, I think it was my senior year, and then that we got this whole specific who does what when between us and the trauma service established. And that has definitely helped us a lot in terms of ensuring that the ED residents get access to doing low frequency, high acuity procedures, chest tubes, thoracotomies, blah, blah, blah. So that's been pretty good. As Matt highlights, every once in a while, there's a little bit of whose turn is it? I feel like that's true of a lot of places. And I think overall, like out of all the places I have ever either rotated at or when I was interviewing or worked at, I definitely feel like we are managing our traumas really well so that both the patients and the emergency medicine residents get both high quality care and then good learning opportunities. The orthopedics, like I agree with Matt's the way he laid it out, like medicine, trauma, and ortho are the people that work with the most probably. And I agree that, yeah, medicine is great. The other big inpatient service is family medicine. Actually, they have their own service, and they are also phenomenal and great to work with.
So easy. Yeah.
Yeah. The problem, as it were, with our orthopedic residents is that they're so good and they're always they're like circulating in the water constantly. And so like they will see things and reduce things or do stuff such that if you're not on the ortho service at the time, like you might miss out on certain basic ED stuff. And so as faculty, we really try to emphasize, hey, in the community, you can just manage this on your own. You don't need to call ortho or X, Y, and Z to like contextualize some of the things that happen. But the flip side is when you're on the ortho service, then you get a lot of work. So that's really helpful. But yeah, our orthopedic colleagues are great. The main benefit of that is that, right, ideally someday you'll all be independent and alone somewhere. And by working at a place where you do work closely with a lot of consultants, there is a risk that you just don't learn anything and you just have them do everything for you, which is certainly an option that you can choose. Or you can use those opportunities to be like, hey man, 3 years from now, when we're both alone in private practice, when should I wake you up in the middle of the night? And like to be able to have that conversation with a peer that you are friends with and stuff is also really helpful because our job, right, is to understand everybody else's emergencies and they definitely see things differently than the way that we might see them. And so to have their expert opinion is so helpful, really helpful. Instead of going, if you work at a place that maybe doesn't have any of these certain specialists in house, and then you have to ship them away, you don't have a chance to follow up with that team about that patient, which isn't the end of the world. It's one more thing you have to figure out on your own.
Great answers. Thank you. Okay, we could talk about the fun stuff. Like, what do you residents do for fun? You mentioned all of the outdoorsy stuff, so you can go into detail about exactly what outdoorsy stuff you do, any kind of wellness activities, maybe journal clubs. If you have a lot of residencies will do different, like at someone's house or at different places. So if y'all do anything like that, just go into depth about all the fun stuff.
Yeah. So yeah, we do journal club once a month, which is always at a faculty member's house, which is great, kind of chill and fun. We have a midwinter retreat where everybody's off and they generally spend the night together at some hotel. And then we all go skiing in the morning, which is pretty cool. And then I would say we're like outdoorsy sometimes to the point, and Andy mentioned it earlier, we don't want to be too outdoorsy. We don't want like a just like very homogenous demographic, but generally people do outdoorsy stuff, but it's so accessible. I mean, it like literally, I could go on a 30-mile trail run to a 10,000-foot peak without driving in a car. Like it's right outside my back door. And so I think when you've got that, like it becomes an easy activity. I don't know, Andy, what other high culture activities am I missing?
I don't know if we have any real high culture activities, but we do.
Fly fishing.
I feel like we just have to, Matt and I technically, right, we're trying to hire a workforce and we need to focus on the job at hand. But yeah, man, like there's a ton of cool stuff to do. And I feel like our program is just as fun people with a lot of fun stuff. Again, the winter retreat started, I think, my second year. Maybe my class was like the nidus of coolness. I don't know. You guys can draw your own conclusions, but it sure seems like it. But yeah, we started our winter retreat then, and it has been a great opportunity to like the winter, no matter where you're at, is like a tough time. And so to have a chance to get out of the department and have protected time to just goof off, it's so great. And then I should acknowledge that I am not a climber. So that's like the one EM demographic thing that I don't do. But yeah, like lots of us also varying levels, right? Some of us are like actual professional athletes when it comes to certain domains, but like there are lots of people that legitimately haven't gone climbing or mountain biking till they moved out here, and they still have a chance to like get in on the ground floor and learn from other people and are not shunned if they don't do any of these outdoor sports. Like we definitely have normal people here that they're like, no, I'm just going to drive to the top of that 10,000-foot peak. Thanks so much. But at the same time, a lot of us, myself included, have definitely gone skinning or mountain biking just before our swing shift and then come into work. And that is the best way to spend time, I think, if I'm totally honest. I don't know if that actually answered the question or not, but
Yeah.
yeah, there's tons of fun stuff.
Okay.
Yeah.
Do many of the residents have children? How does the program support them in balancing family and work?
Yeah. We're in a cycle where actually a lot of people have kids. When I first came 4 years ago, it didn't seem like that was the case, but we have quite a few with kids currently. In terms of balancing family and work, like I had kids in residency. It's very difficult, like just to be transparent. Like there's no magic solution to making it happen. But residents here are unionized. They get guaranteed 3 weeks of leave. They get a wellness half day every 6 months. So there's a lot of protections in place to try to facilitate that sort of wellness. I will say that I think the biggest thing, and this was true when I did residency at Wake Forest, which is a small town. I think the best thing you can do if you have kids during residency is live somewhere with short commutes and low cost of living. I think those are the two things that will impact your wellness more than anything that your program can do. And that I think is a pretty apt description of Albuquerque in that it's an easy place to live. You can live on a resident salary easily. Yeah. I had one other thing. Oh, and then I think there's some, like we do every other week remote conference. I think that's actually a pretty big wellness win to not have to drive in. And like our rule is basically like you can be doing whatever you need to be doing, just have your camera on. And so like people are taking care of their kids at the same time and it's all good.
Yeah. When I was a resident, there were, of the 12 of us, there were two men that had kids. And the reality was, in that circumstance, neither of their wives were in medicine. And I don't think they worked outside of the home. And their wives definitely did most of the work. But now there are definitely more people in general that have kids. And it's definitely hard. We had a kid in fellowship, which was definitely easier than residency, but it's still pretty challenging. I think now there are definitely more people that have more kids. And what before I had a kid, I had zero understanding of like how challenging it is to have a kid, even as the dad that probably doesn't have to. Obviously, there's that whole 9 month gestational period that I'm not doing anything for. Like, there's a lot of work that I don't have to participate in, if I'm totally honest, but it's still a ton of work, obviously. And so, not understanding that when I didn't have kids, like, it was hard, I'm sure, for my co-residents that did have kids. And they're like, listen, man, we can't go out because we need to put the kids to bed or they have to wake up for school. I was like, school, yeah, yeah, yeah. But overall, I feel like their kids were, and I think they still are, right, Matt? Or you can correct me if I'm wrong, but like the kids and extended family were always welcome at virtually everything except for M&M and weekly conference and stuff. So a lot of these extra things that we did, the families were always welcome to come and it was great. And now I'm the guy that brings the kid and has a good time. And it's like phenomenal. Also, UNM's healthcare for residents is actually pretty great. Like when I was a fellow, we had our daughter who was a guest in our NICU for a little bit. So that was cool. He says very sarcastically, but the beautiful part was like we had, there's no bill. That was amazing. It was great to have like people I trusted take care of my family. And then now the union has been able to get, if I correct me if I'm wrong, Matt, but also increased protected time for paternity as well as maternity leave. And that wasn't available in my day, which is not, it still could be better. That's just the reality of life, but like it is pretty good, which is pretty nice.
Yeah.
That is a big
Yeah.
perk.
Like,
I've not heard that for a lot of programs. Big perk.
yeah, Andy was saying with kids being invited to stuff, we even actually moved the hours of our journal club up to not conflict with the bedtimes.
Yeah.
So, because they're welcome to journal club and or faculty wanted to be able to go to journal club and then make it home for bedtime or residence. So yeah, so it's definitely a family friendly town.
We're getting close to the end, but I have another question for you guys regarding, you mentioned several fellowships. Do a lot of your residents end up doing fellowships? And then going off of that, do you have to choose a EMS track to be able to do the air medicine, or is that something that all residents do?
Andy, do you want to tackle the EMS track?
Yeah, no, You don't have to do a track to do a fellowship. The number of fellowship participants obviously varies from year to year, but generally speaking, there usually is a decent fraction of residents that go on to do fellowship, both here at our institution and elsewhere. And it's specifically if residents wanted to fly, that is actually independent of you're interested in any other given a fellowship. It does require a decent amount of work because you have to basically become a paramedic slash nurse. And so there is like a lot of like asynchronous learning and that sort of stuff they have to devote to that. But none of it should prevent you from then pursuing a fellowship in palliative care, toxicology, or whatever. It doesn't necessarily have to be, they don't have to feed into one another. I'm not sure if that answered your question or not.
It does.
Okay, sweet.
Yeah. And then we usually have, it's variable, obviously, but I think we're close to averaging probably half of our class going into a fellowship. This year, we've got 3 doing EMS. We've got
Yeah.
1 doing critical care, 1 doing sports medicine, and 1 doing ultrasound.
Yep.
And they're all staying at UNM with the exception of 1 of those. So people, I guess, like it enough not to leave.
Okay.
Yeah. It usually breaks down to that, like ultrasound, EMS, and critical care. Those are like the most commonly represented ones. And then sports medicine is probably the next most popular program.
Okay. For students who might be interested in medical education, if you are interested in like becoming a program director in some aspect, is it becoming more common that the requirement is to get a fellowship in medical education, or is there still ways to get involved with a program without having that fellowship?
Yeah, it doesn't close doors not to do a fellowship, but if that's the track you want to go on, like I would highly advise it. Not just from a like CV standpoint, like having that line on your CV, but like our medical education fellowship is like a half-time faculty appointment. And then you spend the whole rest of the time like learning how to teach, learning how to be a part of an education department and the ins and outs of budgeting and ACGME rules and all that kind of stuff. So it's definitely advantageous to have some set aside period of time where you're not clinically responsible for stuff that you can learn.
Okay. The month of orientation that you have for interns, what does that look like? What goes on in that month of orientation?
It's
Probably
the
a
best
lot of
month
stuff
of
I don't know
visiting.
about. Yeah. I don't know if the program director knows everything that happens during that month.
Yeah, we can't talk about that.
Okay.
Yeah. It's definitely like during the day, there's a pretty moderate amount of information transmission, like coming in and getting information about whether that's like charting or what do your off service rotations look like. We have an airway course that we put on during July. That's every conference Wednesday is a full day of airway teaching. So that's a big cornerstone of that month is becoming an airway expert, which I think is great to start residency with a real true expert background at airway management. We also have a retreat. We have a camping trip during that month. And then I think the rest of the time, I know I see pictures of them going to do things. I think they drink a lot of beer and hang out a lot.
Sounds like a good orientation.
It's
Yeah.
the best. I can't even imagine that other places don't even do that. But yeah, it's the best. Like there are very practical. You will be able to safely intubate someone the first actual month of the department because we've trained you how to do that kind of stuff. And then yeah, we spend a lot of time just like getting to know New Mexico and Albuquerque. And for people that have never lived in the Southwest, it definitely is very different than the rest of the country. And so you get a chance to like you do not learn Spanish, but we do spend some time like with medical Spanish and like just learning about what makes our different indigenous peoples different. It's not a homogenous group. And so to get to know those people is like super cool. Like we visit some of the pueblos and depending on the timing, they will have like, they're called colloquially feasts. They're like religious celebrations of various significance in different pueblos. And if the timing works out, we'll join a feast and get to hang out then. That's super cool. And then, yeah, you just get to know because you don't work with your classmates like side by side most of the time. usually you'll be in the department together, but you'll each be physically separated and just so busy you can't like talk peer to peer very easily. They'll be your attending and a upper and then you or whatever. So this is a chance to like really get to know your friend and get to make those connections right away rather than spending the rest of the next 3 years learning about one another just in passing. So yeah, it's the best.
I have one last question and then we'll get to the end here. But for third years who don't get the chance, or I guess incoming fourth years who don't get the chance to rotate with you guys, is there a way to interact with your program, whether it be like different, I don't know, some places have activities held at the school or second looks with interviews? Do you guys offer anything like that?
Yeah, we do a second look day, and it's always after we submit our rank list. So that doesn't affect anything. And then for when you interview, there should be a social, it's virtual, right? But a virtual social night that's usually like just residents. So you get a chance with that.
Okay. Well, I won't keep you guys past the time. Thank you so much for taking time out of your schedules to share more about New Mexico with us. I really appreciate it. So if you have any last bits of words of wisdom, you're welcome to share, but I don't want to keep you guys too long.
Andy, close us out, man.
Well, I feel like I've said it already, but right now you guys are consumers and you should be, I know it's easy to get pretty nervous about what your future holds, but really think about what this program, any program can offer you. And are they going to get you to a place that, you know, that you wanted to be in the future? And sometimes we don't know what that future holds, right? Like I did an EMS fellowship and now I'm in education. Like I don't actually do any pre-hospital medicine right now. And like one of the most important things my fellowship taught me was that I didn't want to be an EMS physician. And so it's really important though to give yourself options and opportunities to become the kind of person you deserve to be, even if you don't know exactly what that is. And that is definitely not to say that has to be at a large institution because that's not fair. I don't think that's actually true, but it's more about knowing yourself and knowing what you want for yourself so that then you can find, do I want to be in a smaller community kind of training place because I know that's what I want to do, or that's important to me and my family, or like what kind of large ivory tower institution do I want to be at to accomplish the specific goals I have for myself? Because these next 3 or 4 years are going to be challenging, but should be also really fun and rewarding. And you should seek that out for yourself because you worked really hard. You deserve to be stoked about where you're at.
Great. That's some of the best advice we've had. So I appreciate that. Okay. Thank you again so much, students. Thank you for joining. If you have any questions, feel free to email me. Happy to help answer those questions. And again, Dr. Frederick, Dr. Berglund, thank you so much for taking time out of your schedules. We really appreciate it.
Yeah. And don't be shy about like just texting me if you have questions.
Okay.
I'm happy to just respond. No problem.
Yep. Same.
All right. Thanks, everyone.